Hello, everyone. My name is Christina Nemeth, and today I will be presenting my final CILE project, a systematic review titled Minimally Invasive Treatment Options for Obstructive Sleep Apnea in Adult Patients Who Fail CPAP, a systematic review of the literature. Obstructive sleep apnea is a prevalent and serious sleep breathing disorder characterized by the intermittent obstruction of the upper airway during sleep, which leads to periods of oxygen desaturation and sleep fragmentation. Such disturbances in normal sleep architecture lead to symptoms of significant daytime sleepiness, morning headaches, difficulty in concentration, and depression. Significant daytime sleepiness poses a major risk in public health, as it can affect daily functioning, cognition, mood, and the increase of risk of motor vehicle accidents. Sites of upper airway obstruction in OSA include the nasopharynx, oropharynx, and the hypopharynx, with the majority of people having a multi-level obstruction and the oropharynx as the most common site of obstruction. According to the National Healthy Sleep Awareness Project, OSA affects at least 25 million adults in the United States, thereby threatening public health and safety. Approximately 3 to 7% of males and 2 to 5% of females have OSA in the United States. OSA has been shown to increase the risk of motor vehicle accidents, hypertension, heart disease, type 2 diabetes, stroke, and depression. Obesity, alcohol, and tobacco use also increase the risk of having OSA. OSA is diagnosed by polysomnography, and the severity is measured using the Apnea-Hypopnea Index. Diagnosis of OSA is defined as an AHI of over 5 and then categorized as mild, moderate, or severe. Subjective evaluation is then performed using the Epworth Sleepiness Scale, which is a numerical scale of subjective daytime sleepiness with a score of greater than 10, indicating significant daytime sleepiness. The treatment for OSA falls into 3 main categories: conservative, which includes weight loss and sleep positioning, CPAP, or devices such as CPAP and oral appliances, and surgery, minimally invasive or invasive. The current gold standard for its high efficacy is continuous positive airway pressure, or CPAP. Despite the efficacy of CPAP in reversing sleep apnea, studies show 29 to 83% of patients are non-adherent, using the cutoff of at least 4 hours per night to define adherence. Traditional sleep surgery, such as UPPP, tonsillectomy, and maxillomandibular advancement, have been reserved for those who fail CPAP therapy as either second or third line. Nonetheless, surgery for OSA, especially with the use of general anesthesia, has shown increases in morbidity, mortality, and postoperative complications. Focus has now been placed on finding minimally invasive alternatives for OSA that are effective with low morbidity and complications. In this systematic review, the literature on minimally invasive alternatives available in an office setting for OSA are reviewed. Now, the objective of this systematic review is to summarize the current data on the effectiveness of minimally invasive treatments for adults with obstructive sleep apnea. In this systematic review, articles were searched using Medline, Google Scholar, and ScienceDirect databases from January 2000 onward. Literature search was conducted using the keywords OSA, minimally invasive, Apnea-Hypopnea Index, and the Epworth Sleepiness Scale, which yielded about 7,988 results. Articles were then selected based on the following criteria: adult population, procedures that use local anesthesia, and inclusion of pre- and postoperative AHI and/or ESS. Prospective, retrospective, case series, non-randomized, and randomized clinical study designs were included within this review. Excluded from the search were children, treatments that necessitate general anesthesia, and combined surgical interventions, invasive with minimally invasive. 15 cases were selected using the above criteria and then categorized based on procedure type, either pillar implementation or implantation, radiofrequency ablation of the base of tongue, and cautery-assisted palatal stiffening operation or / anterior palatoplasty, ND-YAG laser-assisted uvulopalatoplasty, and multi-level single-stage minimally invasive treatment. All procedures listed aim at correcting sites of obstruction within the oropharynx, the most prevalent site of obstruction within OSA. Primary outcome measures and secondary outcome measures used were the preoperative and postoperative AHI and ESS respectively. Analysis of the data was as follows. 13 studies included pre and postoperative AHI at 3 to 6 months. 3 of the 15 studies included long-term results for AHI, and all studies showed a significant reduction in AHI overall. However, using the most accepted criteria for OSA treatment success, as a reduction in AHI of greater than 50%, pillar implants was the only category in which greater than 50% of AHI reduction was not achieved. As this study focuses on those who fail or refuse CPAP, any significant reduction in AHI was deemed to be effective. The ND-YAG laser-assisted uvulopalatoplasty, the newest of the minimally invasive treatments in this literature, yielded the highest percentage reduction in AHA for mild, moderate, and severe OSA. Additional studies and higher level of evidence is needed to validate this single study finding. 10 out of the 15 studies included pre and postoperative ESS scores, with all studies that included ESS having a postoperative ESS score of less than 10. Thereby, all were effective in reducing the daytime sleepiness. Overall percentage reduction in AHI and ESS was calculated based on the extracted data from selected studies, and a summary of the data findings and the calculated mean reduction in AHI and ESS can be found within Table 1. The level of evidence of each study was determined based on study design and methodology, yielding level 1, 2, 3, 4, or 5 level of evidence. Although all minimally invasive treatments proved to be effective, most of the data is level 2 or 3. Only multi-level, single-stage minimally invasive treatment had level 1 evidence with a 57% reduction in both AHI and ESS. Since the majority of those with OSA have multi-level obstruction, multi-level minimally invasive treatment focusing on the specific patient and their individual anatomy has the highest potential for treatment success. However, additional high-level and long-term studies are still needed. In conclusion, based on the studies selected, minimally invasive procedures such as pillar implants, RFA of the base of tongue, anterior palatoplasty, ND-YAG laser-assisted uvulopalatoplasty, and multi-level single-stage treatment are effective in reducing the AHI and ESS in those with OSA. For patients who fail CPAP and surgery is not an option, any one of these minimally invasive treatments can be utilized to effectively lower the AHI and ESS, depending on the individual patient's sites of obstruction, thereby decreasing their symptom severity. Long-term data for such interventions is still scarce, and studies with higher level of evidence data is needed to solidify the significance of current findings. Randomized controlled trials for these procedures will need to be conducted in order to increase the level of significance of current findings. Thank you very much.